Hello again. Our next speaker is Dr. Jean-Philippe Langevin, and he will be presenting on advances in epilepsy surgery.
Thanks, Natalia. So thanks for inviting me for the talk, and thank you for your attention today. So I'm I'm a neurosurgeon at the West Los Angeles VA affiliated with UCLA, and I'm the epilepsy surgeon for the group. And so today, it's been an exciting time in epilepsy surgery. I would say in the last 5 to 10 years, because we've seen a lot of new technology, a lot of new techniques emerging. And there's been those efforts basically are leading to two separate advancements. So like one is the surgery are done more minimally invasive than before. And also patients who are not eligible for surgery or did not have any surgical options now have new options basically. So I'll go over that today to present the new opportunities or options. And so the two things that I'm going to be focusing on are, first of all, so the so-called laser assisted resection of seizure focus. And the second part is going to be on neuromodulation, so where we place implants to control seizures. And so first of all, on the laser assisted ablation, so that's a new technique, again, that's emerged, I'd say, in the last 10 years or so, and it's really picking up. It's where we know that there's a seizure focus. We know the area that's triggering the seizure inside the brain. And traditionally, we would make larger opening inside the skull to reach the area and resect the tissue with conventional technique. Now, instead of that, we can use a small laser that looks like the size of an electrode or essentially a little bit bigger than a spaghetti noodle. And so that laser is inserted surgically inside the operating room, precisely into the spot that causes the seizure. And so once that is completed, then the patient is transported to the MRI under general anesthesia. And then a lesion is performed. So like the area of the seizure is removed, if you will, using the laser instead of going in surgically. And so I show here on the next slide just a little bit what it looks like. But one of the advantages, as you can see on this picture, is that it's minimally invasive. So instead of having larger incisions on the scalp and larger opening in the skull, the only thing that's needed is really like a 5-millimeter opening with we use a small twist drill, basically just enough to insert this T-shaped holder. And so that anchors the laser, which is this filament here, in place, and then it allows the laser to be guided directly along the trajectory down to the precise target where it needs to go. So the advantage to that are that it's minimally invasive, so it's a smaller opening, so which means a faster recovery for the majority of the patient. And obviously the other major advantage is that if we have to reach deep-seated targets or areas inside the brain, we can do so without going through a large corridor of tissue, and I'll show an example of that. So this part is performed again under general anesthesia in the operating room, and subsequent to that, the patient is carried over to the MRI environment. And then an MRI image is obtained. So you can see here like a patient with a laser implanted inside a seizure focus down the specific trajectory. In this case, the patient has temporal lobe epilepsy, kind of a traditional area for left-sided temporal lobe epilepsy. And so the laser is in place. And then essentially what we see on this slide is the information that we obtain from the MRI once the therapy is started. So the patient is under general anesthesia in the MRI, and the laser is placed inside the specific trajectory. And repetitive MRI images are obtained in sequence. So nonstop, the MRI is taking pictures of the brain to update it. And basically the software that's connected to the laser uses the MRI images to come up with a thermal map. So meaning the temperature inside the tissue around the tip of the laser. And so you can see the color-coded thermal map on the top left here. So with the red center being the highest temperature, and then as it becomes more blue, the temperature drops down to normal. And you can see at the top of the image here, like the actual Celsius of the temperature of the tissue. And so once we reach a certain degree of Celsius, we know that the tissue is essentially resected or removed. So that allows us to have very controlled lesion or removal of tissue, making sure that only the areas that are causing the seizures are being removed without damaging anything surrounding the area. And in fact, you can place on the software seeds to limit the amount of temperature, so that if you say, okay, I don't want the laser to damage any of those structures, surrounding the area of interest. So you can place a seed, and once the thermal map reaches a certain threshold, then it stops immediately the laser without the surgeon having to do anything. So that's like a safety feature that's included inside the software. So once the lesion is performed after a few minutes, then the provider obtains this orange color coded area. And so that's a summary of the therapy that tells the surgeon that the orange area is the one that's been resected, basically using the thermal injury to the tissue. And so that area should be completely inactivated. So the idea there is to have this orange section to be overlapping the seizure focus. And so at the bottom is an animation that shows in not in real time, but in accelerated time, what we would see during the therapy delivery. So that's performed over quite a few minutes. And so you can imagine that the provider has a lot of time basically to either stop the device or place seeds on the surrounding to make sure that the laser stops when it's needed. So the advantage to this technique, again, is that it's a very small corridor of entry. So like the tissue leading to the area of interest that needs to be resected is preserved. So all the tissue outside the area is untouched. It's a small opening, as we said. And also the resection is done essentially under live image guidance, meaning that the surgeon is updated continuously on the status of the tissue being removed. And in fact, the procedure is performed with multiple team members present. So the radiologist is there, the neurologist who controls the seizures, and the surgeon. And so the decision is made live as to, like, if enough tissue has been removed, if a change needs to be made, or if more ablation needs to be performed. And essentially using that technique, we can do several areas of thermal resection. So like this was the first area here that we saw on the previous slide. But this patient needed further resection to control the seizures. And so what's done simply is just pulling back the laser slightly under live update images from the MRI to make sure that we're in the proper area. And then we can repeat a second or even a third lesion down the appropriate path. And so then we have a summary of the entire lesion that was performed on the patient. So like in this case, approximately 4 centimeters of tissue was resected. And again, the area surrounding this part of the brain is completely preserved. So only the seizure focus, the relevant area is removed, and the rest of the brain is untouched. And following the procedure, we do one last MRI with contrast injected inside the vein. And the contrast then highlights the zone in white here and bright region, the area that was subjected to the thermal injury. And so it highlights the area where the tissue was resected as seizure focus. And And what we wanted to show here is you can see how like the orange area on the left side essentially overlaps almost perfectly the region that's confirmed with the contrast injection. And once that is completed, and then what is done is the laser is simply removed, and the holding device is also removed from the skull. And only a few sutures are needed to close the scalp, and the patient is awoken from general anesthesia after that. And so currently, multiple indications have been deployed. So I show a case of temporal lobe epilepsy, which is one of the most frequent use for this technique. But other authors, other centers have used it to treat lesional epilepsy, or epilepsy that's caused by various lesions inside the brain. And so this is an example where the arrows at the top, it shows regions of heterotopia, so like areas of the brain that are abnormal. And those areas were all separately targeted with laser ablation. And so you can see the final image where there's a little bit of swelling, a rim of white swelling around the region where the laser essentially performed removal of those tissues. And again, you can notice on these MRIs that the rest of the brain is completely untouched, using this technique. And this was another example in this case where the laser ablation was used to treat a very deeply seated lesion, so a so-called hamartoma causing gelastic seizures. So the challenge here is that those areas are deeply seated inside the brain, and so it'd be a long way for the surgeon to get in that region safely through conventional technique. And so the laser really offers a lot of advance just by using a very narrow path to reach this deeply seated lesion. And then again, the thermal map provides this orange color zone predicting the total area treated with the laser. And you can see once they use the contrast enhancement agent, it's basically overlapping that region almost perfectly. So in this particular study from 2013, they had 10 patients with a short-term follow-up of 6 months without complication. In their hands, they had 90% success rate of seizure freedom. So meaning that at the very least, we know that the laser ablation is accomplishing its role of resecting or removing the area causing the seizures. And so in this slide, it was a summary across multiple epilepsy centers in the United States. It's still like now dated from 2013. By that time, 13 epilepsy centers had contributed the data using the laser for temporal lobe epilepsy. And you can see here at where it says angle 1, so like seizure freedom, over 50% of the patients that achieve seizure freedom with a very low rate of complications. And so this slide is a little bit busy, but it is important because what it shows here is outcomes of neuropsychological data following the laser ablation. And as you know, for patients who are considering or being considered for epilepsy surgery, they are going through intense neuropsychological testing prior to the surgery to see at what level of function they are. Sometimes the test can predict where the seizures are coming from by looking at which areas of the brain are being affected or which domain of cognition are being affected. But the other role of the neuropsychological assessment is that we can then repeat it after the surgery to make sure that the patient is the same and they're no worse as a result of the procedure. And so these, each column here, BNT, CAWA, animal, so each of those are actual neuropsychological tests. And the blue bar are so the good outcomes after laser ablation, and the solid red bar is a good outcome after conventional open surgery. And so the good outcomes are no change essentially from baseline in neuropsychological assessment. And you can see that the blue bar, beats the solid red on quite a few of those assessments, especially here towards the end on those two CVLT type of neuropsychological testing. And so generally speaking, that is an argument in favor of the fact that since a lot of the tissue is being preserved as part of the procedure, perhaps that leads to better cognitive outcome after the procedure. So again, so the role of the laser not only being a minimally invasive approach, but also preserving more brain tissue while still achieving a good seizure control. And final piece of information was the length of stay. And so this is just a distribution of patients over time and the number of days that they're staying in the intensive care unit in gray versus the number of days they're just staying in the hospital in general in green. And as you can tell, the majority of patients are essentially discharged day one, and most of the remaining patients go home the subsequent day, which means that from this procedure, patients can expect having a small incision, approximately 5 millimeters, and going home after laser-assisted resection of the seizure focus between 1 or 2 days after the procedure, and experiencing approximately 50% chance of being seizure-free after the procedure. So that's one of the new advancements that we've had recently in epilepsy surgery, and probably will play a role at the very least as a first step, prior to conventional resection, since there's not much to lose in performing a laser ablation, and if need be, to then proceed eventually with a more traditional type of removal. The second part of the talk was about neuromodulation. And so what neuromodulation means is simply a placement of an implant inside the specific spot inside the brain. And this electrode is then connected to a generator or a battery, basically, that sends an electrical current to that specific target to accomplish a role. In this case, stopping or reducing the occurrence of seizures. And so as you can see on this image, the important thing to know, a lot of patients ask me, with those implants, are they visible from the outside? And so all the components, the electrode, connecting wires, and the small computer or pulse generator are all internal under the skin. So, you can see a small profile where it's inserted under the skin, but it's not like a component is visible on the outside. And the other question that I often get is, are there limitations in activity after the placement of the stimulator? And essentially, the idea of the surgery is to have patients return to a normal life. So there's no real limitations in terms of physical activity that could be performed outside of the typical limitations from seizures, if they're not fully controlled. The device is then non-invasively communicating with a programmer. So in this case, it looks like it's actually a tablet, an iPad tablet. And the electrical current is at lemon-shaped purple areas. And so the neurologist can then control how much intensity is being delivered and follow the occurrence of seizures over time. So that's what neuromodulation refers to. And there's essentially two subtypes that we currently have. The first one is called responsive neurostimulation, and the second one, deep brain stimulation. And so in terms of the first one, so responsive neurostimulation, in this instance, we need to know where the seizure focus is at. So those are patients who typically have undergone electrode placement, inside the brain, and monitoring for a week or two inside the hospital. And we're satisfied that we know where the seizure focus are coming from. But for a reason or another, we are unable to remove that seizure focus safely. So maybe it's an area of the brain that controls something important like language or memory, and it's not possible to remove it either by the laser or conventional techniques. And typically, those patients would have been unable to be offered any type of surgery. So that's where neuromodulation plays a role. So now that we know where the seizure focus is at, we can then place an electrode inside that area. And the role of the device is to detect the seizures when they're about to come in and to send a little bit of electricity to abort it. And so on this slide here, it's an animation from the company that makes the device. And it kind of shows how it works. So you have the electrode that's placed inside the seizure focus, and you have the little computer or the generator that's inside the skull. So it's sitting flush to the skull under the scalp, so there's nothing visible on the outside. And the device must monitor all the brain waves. It detects when there's something abnormal, and then it's going to send a signal to respond. And so the blue line here is when everything is normal, and your red zone here is when there's a detection that a seizure is about to start. And then you can see that after that, the device sends an electrical current and aborts the seizure. So detection, then the electrical current in green, and then the seizure is aborted. So then the device continues to monitor the activity continuously like that. And so this device is continuously monitoring there chronically inside the brain the activity and treating only as needed. Then the patient uploads that data once a day, and the physician gets a summary of all the events that has occurred since the last visit in the clinic. So the purpose of that device is that not only does it help with treating the seizures, but also it keeps a nice diary of how many seizures have occurred over the last period, since the last time the patient was seen in the clinic, and at what time of the day they're happening. So in some cases, medication adjustments could be performed to get even better seizure control. And so just going over briefly how we perform the surgery. So the first step is to place small anchors or markers inside the skull at 4 small spots. So this is done under anesthesia, local anesthesia. And then a device that's 3D printed, custom made, is created. Each leg of that device fits into one of the markers. And once it's fixated in place, as it shows on the picture, then the 2 electrodes can be guided directly on the intended target. So that's what we do on the day of the surgery. So you can see on the green area how the electrodes are inserted precisely. And again, it's minimally invasive in the sense that only a small twist reel is needed to insert the electrodes. And the final electrode placement, so there's a generator that's located under the skin flush with the skull. So it's secured in place in that area. And that computer is connected to those 2 electrodes. And then we can treat the seizures. So this is a slide just essentially showing the final trial that was performed by the company to obtain approval. So that was already in 2014 now. But 50% of the subject had temporal lobe epilepsy at that time. And as you can tell, a large number of them had tried multiple medications, obviously, but also even a vagal nerve stimulator, and still had intractable seizures. And this graph shows the response of the patient. So starting here, those are patients who had benefits from the procedure. And at this particular point, patients experience at least 50% reduction in the frequency of seizures. So you can see that over 50% of patients had at least half of their seizures cut down from the implant. And in this slide, what I want to show is that the response from that type of technology builds over time. So at 1 year, the median reduction overall of seizures was about 44%. But when you wait 2 years, because the device is adjusted and because the brain also learns from the treatment, then you had over 55% response in terms of reduction of seizure frequency. And this effect continues to build in the future. With neuromodulation, it's virtually impossible or very rare to achieve 100% control of the seizures. So we always aim to reduce the frequency of the seizures and to also reduce the intensity of the seizures. So we can never really cure seizures. And essentially, we can see here the battery lasts for about 4 years, 5 years with the newer devices. But then that small area, the small battery needs to be replaced through a surgery where essentially is disconnected from the wire and then replaced with a new one, and the scalp is closed on top. So the last technology was deep brain stimulation. And again, it's very similar to the one I just showed, the responsive stimulation, in that an electrode is placed into a precise location inside the brain. But the main difference with this one is that the signal is continuous. So with the prior one, the stimulation only occurs as needed. With this one, there's a continuous signal sent to the brain to introduce a lot of white noise and basically eliminate the seizures by disrupting the network of generating epilepsy. And showing the steps again of how the procedure is performed in a very similar fashion. We place markers for the patient using local anesthesia. So the markers are the same as we use for the prior surgery with a tiny incision of approximately 3 millimeters. And then again, a custom built frame is designed, 3D printed for the patient, a single use. And once in the operating room, that frame is connected to the 4 markers, then it guides the 2 electrodes directly where we need them to go to control the seizure focus. So this is how the electrode is inserted. And finally, as I mentioned, the entire system is hidden under the skin. And in this case, the generator is placed under the collarbone through a small incision. This slide, again, just to show that the patients were highly refractory through medications. In this case, almost half the patient had gone through a vagal nerve stimulation in addition to medication. Just going to show this one here, or a very similar fashion, where the majority of patients experience more than 50% reductions in their seizure occurrence after the introduction of the stimulation, with a response rate of 54%, response being defined as more than 50% reduction in seizures. And as I mentioned for the prior technology, the benefits build up over time, so that after 2 years or 3 years of stimulation, we can expect further reduction in the intensity and the frequency of the seizures. But similarly, it's not possible to achieve a complete remission of the epilepsy. So in conclusion, I wanted to show today new techniques that we have available to us in epilepsy surgery. Those techniques are making the surgery more minimally invasive and also allowing new options to patients that previously were not surgical candidates, so that patients who have highly refractory seizures that are unresponsive to medications can still benefit from these types of surgery. Thank you very much. And on that, I'll take any questions if there are any.
Thank you, Dr. Langevin. Let's take a look. Doesn't look like there are any questions now, but thank you for that wonderful and informative presentation. And I think we're done for the next talk.
Thank you very much. Bye.
Take care. Bye.